was fortunate that I had a summer job when I was an undergraduate science student working in a disabled ex-servicemen's hospital to get a point in my life where I actually realised that doing general science wasn't something that interested me. Actually working with people, working with patients was the issue. And that changed my whole look on life. So having done that summer job, applied to become a nurse, it was going to be a almost 2-year wait to become a general nurse. So I took the option of getting on to becoming a mental health nurse training program because I could start that in 6 weeks' time. So I made that decision to change. And looking back on it, training originally as a mental health nurse, looking at the different aspects of mental well-being, became the kind of foundation of why I moved into public health many years later. And that interest in mental well-being, the difference that it makes to people's lives and communities' lives, was really the kind of foundation that's taken me through my career. And though I don't directly practice as a mental health practitioner, it's remained a central part of whatever I do and how I look at public health problems, public health challenges. It's arguably a strange interest for me because I was born and brought up in a large town. I worked in Glasgow, I worked in places like Stirling, Liverpool, Manchester over the years. So taking on the post of Director of Public Health for one of the largest rural areas in the country was quite a step change. But what it highlighted for me was that rural communities, the needs of rural communities, had been not looked at seriously by successive governments. And consequently, it taught me a lot about what I didn't know. And so meeting with the farming communities, meeting with people in their villages and hamlets across Shropshire and latterly Herefordshire, really brought home to me how much this country thinks of deprivation and health inequalities in terms of urban health inequalities, and that the resources that are given to support rural communities in comparison is very poor. So from my point of view, that learning curve was huge. It was also an element for me about understanding things that had never occurred to me at all, such as how people heated their homes and the reliance on oil fuel, how fragile the rural economy was in comparison to the urban community. The spells of bad weather that we've seen recently are classic examples about how much farming and the rural communities are affected adversely by poor weather. But also this element about how, in dealing with national government and dealing with ministers and lobbying organisations such as Local Government Association or what was then Public Health England on rural health issues, how much people didn't understand and how much the affluence that is sometimes in rural communities can overshadow quite significantly the health inequalities that rural populations face. Chris Whitty, as the Chief Medical Officer for England, has really taken this on as an issue. His forthcoming annual report will be focusing on the health needs of small towns and rural areas. So it's great to see somebody of Chris's reputation taking this forward. And I think there's a number of things for whether it's somebody like myself coming in from a public health perspective or anybody working in rural areas. First and foremost is understand your community. There are assumptions that we can make about the rural idyll and how lovely it is and how easy it is to overlook the real challenges that communities face in terms of health and well-being, finances, heating, all of those issues that we can take for granted because we see the potential affluence that's there. I think the other aspect about it is there needs to be a consistent challenge from the various sections of the rural economy to get equality of opportunity. Now, we recognise that if you live in a rural area, that things such as railways, bus routes, etc., may be less accessible than they would be in an area like London or Manchester or Liverpool. But that doesn't mean that the society can ignore the challenges that rural communities face, and that there needs to be investment in the needs of rural communities, and that is in many forms. It's not just in the support of the farming community itself, but it's recognizing that you have to have the ability to deliver health and social care services in an entirely different way than you can in central London. And that hasn't been recognised enough by national governments over the decades. Mix of things come to mind. I think first and foremost it is a better understanding of the true costs of living in a rural community, and recognising alongside that it's not an us against them. It's not a case of urban areas are bad, rural areas are good. It's actually a recognition that there is a synergy between them, that there is the complementary nature of them. We need strong farming communities, we need strong rural communities, whether that's for the growing of crops, to the natural beauty that we have, but also the aspect of people needing access to good quality green space. So if we don't recognise that complementary need, we're missing the point. And linked to that is a recognition that models of health and social care that are based on urban ideas, and we saw a lot of this in terms of things like COVID and the pandemic. Urban models of care don't work in rural areas. One of the elements that's not sufficiently recognised is the travel time that staff and the public have to get to various things. So even if you are still requiring somebody to attend a hospital, public transport links are poor. The time it takes someone, particularly someone who may have a long-term health condition, to get to a hospital is significant, both in terms of the time it takes them to get there, but the energy required for that person to spend their whole day travelling, to then wait in the hospital for a long period of time and then to come home. So consequently, we have to look at issues about how we use telehealth care better, how we make services much more accessible in rural areas, but also how we construct things like outpatients appointments in a way that fit in with the needs of the people that we're serving rather than the needs of the hospital. Similar aspects there in terms of recognising that if you have social workers or health visitors or district nurses visiting in the community, they may be seeing the same types of patients that they would see in an urban environment, but the time taken to get between those visits can be up to 5 times longer than it would be in an urban area where there's a greater population density. And that particularly applies when we have bad weather. So the recent snows, the recent flooding, all the recent things like that significantly add to the time it takes for care to be delivered. Yet funding and public health grants, a good example of it, rewards urban areas and penalises rural areas. The area that I work in at the moment gets £50 per head of population An area like Kensington and Chelsea in London gets £159 per head of population. So why is it that in the eyes of the formulas that have been created to allocate public health funding, someone living in Cheshire East is rated £110 less than someone living in Kensington and Chelsea? Now, that's not to say that Kensington and Chelsea doesn't need that money, but why does the system have such a significant difference between rural populations and urban populations? I'm lucky in the respect that I was involved with CHAMPS at its early stages when I was working in Sefton and Liverpool. But I then spent 10 years away from it working in the West Midlands. And though we had a good public health network, it wasn't nearly as strong and collaborative as CHAMPS was then, is now. And so coming back to work within Cheshire East, Cheshire West, and the Merseyside and Cheshire ICB area, what was clear for me was that even though lots of the people who had been in post when I left had now moved on to other roles or had retired, the strength of that collaborative was still there. There was that level of trust, that level of cooperation across the 9 areas. And linked to that was this element that a shared understanding of when they could use that collective voice to advocate on behalf of the populations that we served, even though our populations are significantly different in terms of size, breakdown, all those, size of population, size of the areas. All of that still allowed us to work very collaboratively as a CHAMPS group, but also to not limit that to just the narrow area of the 9 public health teams. It was actually working across the whole of the patch and using CHAMPS as a vehicle to work with other people, and that's a superb strength, and why, albeit that what we had in the West Midlands was good, CHAMPS is far, far better because it's much more than just a collective of directors of public health and consultants in public health. It is a much stronger voice on behalf of our collective populations.